you could potentially just have a new cancer patient, and along with this major acute crises that they've had, so dealing with a cancer diagnosis and having had TTP, or, trying to figure out if it was medication, how do we resolve that? Are we able to find a different drug and switch to a different regimen, or do we continue to give it because it's the only therapy?
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, and today we're talking with Amanda Weatherford, a clinical nurse coordinator at the Fred Hutchinson Cancer Center in Seattle, Washington, about Thrombotic Thrombocytopenia Purpura, which we will refer to as TTP, because I cannot say that right again. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Amanda.
Thank you for having me.
So to start, as I said, TTP, Thrombotic Thrombocytopenia Purpura, TTP.
It's a mouthful.
It's a mouthful. Can you briefly explain what TTP is?
TTP is Thrombotic Thrombocytopenia Purpura. It's part of a class of diseases called thrombotic microangiopathic anemias, which themselves are defined as intravascular hemolytic anemia with concurrent thrombocytopenia. And then specifically, TTP results from a severe deficiency in von Willebrand factor, cleaving protease, Adams ADAM TS13. This leads to a deficiency that causes a prevalence of von Willebrand factor multimers that attract platelets and create thrombi in the microvasculature. And these microthrombi themselves cause shearing of red cells, which causes the intravascular hemolysis. To break it down, this disease attracts all the platelets, so you become thrombocytopenic, and then you are also creating thrombi, so you're thrombotic, and then you're also causing hemolysis by the actual physical shearing of the red cells against the thrombi in the vasculature.
There are two types of TTP, and how common are each of those types?
So there are two types. There's a congenital, which is very, very uncommon. These are typically found in neonates, and then occasionally they show up in pregnancy. This is approximately less than 5% of the total TTP diagnoses. The other one would be immune TTP or acquired. It is the most common. It's 95% of all the cases, and it is what we as nurses are most likely to encounter in our practice.
Okay, so the immune TTP or ITTP is what oncology nurses are likely to see and need to be more familiar with because that's what they're going to encounter. Okay. So how can ITTP present similarly to other thrombotic microangiopathies, coagulopathies, or other thrombocytopenias?
Fortunately, we have hematologists who are trained extensively in this kind of thing, but some of the things that we as nurses can be on the lookout for are understanding the differences between different diseases like TTP or immune thrombocytopenia purpura or DIC, which many people have seen in oncology nursing, or even the other types of thrombotic microangiopathies like hemolytic uremic syndrome. So commonly in TTP, you have an increase in bleeding time, thrombocytopenia, and what's called schistocytes, which are the actual broken down red blood cells in the smear, and the hemolysis. Diseases like ITP, you have an increase in bleeding time, thrombocytopenia, but no hemolysis. And then DIC, you have all sorts of derangements of clotting, like increase in bleeding time, elevated PTT, elevated D dimers, low fibrinogen. Those are typically more found in sepsis or trauma patients. And then in order to differentiate TTP from the other hemolytic thrombotic microangiopathic anemias like hemolytic uremic syndrome, we would pay more particular attention to kidney function, which is kind of the defining characteristic of hemolytic uremic syndrome and separates itself from TTP. So in that case, it'd be like elevated creatinine, kidney failure, hematuria, in addition to all the bleeding time and thrombocytopenia.
Well, as you mentioned early in that response, this is a team approach to understanding all of these different disorders. And so that's reassuring for me as I'm listening. And I'm like, I don't know how I would ever keep all of this straight. So that's a great point to keep in mind, is that we can learn and lean heavily on our physician colleagues or advanced practice providers and work together to either acknowledge, diagnose these conditions. So that's reassuring to hear.
I am a firm believer in understanding these kinds of things also helps the relationship with the hematologist. So
yeah, absolutely. And
it's interesting.
It is interesting. It is overwhelming and I think a little intimidating, especially if I speak for myself, I suppose, but for someone who did not work closely in hematology during my direct care days, this was always something that just felt a little too nebulous to quite get my arms around. But that's why we're here today, to learn a little bit more about it. So what are some of the health issues that can cause ITTP?
For folks who develop acquired TTP, is oftentimes found in people who've gotten HIV, lupus, or other connective tissue disorders. It can show up like congenital TTP in pregnancy, but also can show up after traumas or major surgeries, some medications. But more specifically for the oncology nurse, it can show up in cancer and also as the result of chemotherapy and medications. They say it's either a system of malignancy or a consequence of treatment. And it also has shown up in patients who are post-allogenic stem cell transplants.
That's very interesting. So because of the disease itself, it could be a subsequent result of the treatment we give to help treat the cancer. And so we're presented with problems on both ends of that spectrum when we're looking after our patients with cancer. What are some of the symptoms that oncology nurses should be aware of to assess their patients for ITTP?
I think as hematology nurses, me specifically, understanding the pathology helps me understand what to look for in a patient who we would suspect has TTP. So you would look for signs of things like thrombocytopenia, like abnormal bleeding, large bruises without any corresponding trauma, petechiae, epistaxis, gingival bleeding after brushing your teeth, stuff like that. And then we would also be kind of on the lookout for some of the sequelae of forming these clots, the thromboses in the microvasculature, like neurologic abnormalities, changes in cognition. One of the classic things in TTP is that there's typically a fever that corresponds. And then you also need to look out for the signs and symptoms of anemias like pallor, just overwhelming fatigue, headaches, shortness of breath with minimal exertion, palpitations, dizziness, lightheadedness. And then another thing that shows up in TTP that a nurse should look for would be signs of renal dysfunction. The products of the hemolysis can cause some issues in the kidneys, which would elevate creatinine, have hematuria, so dark urine, some of the other classic things like low back pain, that kind of thing.
Are there certain patients or certain diagnoses, disease types that put a patient at greater risk for developing ITTP, or is it similar risk across the board?
They find TTP more frequently, or they feel that it's more frequent in adenocarcinomas. And then there are specific medications and chemotherapies that have shown up to cause or lead to TTP. The medications that have been found to lead to TTP are calcineurin inhibitors, mTOR medications, and then some of the medications used in conditioning for stem cell transplant like busulfan, and then hormone therapies also.
That's really interesting. As I hear you giving us that great summary of kind of what to look for and some of the conditions or medications that might bring some additional risk to developing ITTP, it all still seems like those are symptoms we see in a lot of things. In a previous episode, when we talked about DIC, we had a similar message where it was like, this will be something that will be hard as a nurse to instantly know, oh, this is TTP. But it's more keeping that awareness tucked in the back of your mind to say, okay, I've learned about this. Here are some of the risk factors. Yes, they are somewhat general and can overlap with several other conditions, but just kind of keeping that possibility in your mind as you're doing your nursing assessment is always an important first step to making sure you can then advocate for kind of investigating it further with the clinicians and with the other providers that you're working alongside.
I totally agree. Like I had said earlier, fortunately, as nurses, we're not going to be diagnosing these things, but knowing that it's a possibility and being able to identify when it's time to raise your hand and let somebody know that you have concerns that there's a real emergency happening.
Absolutely. So how is ITTP treated in patients with cancer?
It would be no different than patients who just have idiopathic TTP. Once you suspect that TTP is in the play, you would immediately start the patient on plasma exchange or plasma pheresis daily or twice daily, and also on high-dose steroids. You do that pretty much until you start to see improvement in platelet counts and some of the other hemolysis markers like LDH. And then it's kind of a gray area, but there's been some movement among hematologists of moving to using rituximab or caplacizumab first line in patients with TTP. So after initiating the plasma exchange, they would also give the patient rituximab and then also caplacizumab.
So how long does treatment typically last? Is there an average time?
For a lot of patients, once they start therapy, recovery happens quickly. Usually in 3 to 5 days, you can expect the platelet count improves. It depends on the patient if this is their first episode or if this is a recurrence, which changes how severe the disease is and how much medication it takes. But usually within a few weeks, we can expect that the patient's not necessarily cured, but they're moving towards remission.
So you'd mentioned the relapse. So relapse is a possibility. How often does that happen?
In approximately 40% of people who've had TTP, we would expect that they relapse.
So what happens if a patient, we pick up on the early signs of ITTP, but for some reason, then maybe that they go without treatment, or we don't pick up on those signs of ITTP and they don't receive treatment? What happens in that situation?
Unfortunately, non-treatment or non-management of TTP would be fatal, just because of the catastrophic nature of the disease. You're clotting, you're hemolyzing, and you're bleeding. So without treatment, it's pretty much fatal.
So what are some additional conditions if a patient does develop ITTP? Are there other conditions that they can also develop at the same time?
So kind of the sequela of TTP, so things that may happen even after you've gone into remission. Usually people continue to have some of the neurologic changes, and a lot of times they don't completely resolve. And some things like major depression has been found in patients with TTP.
That's interesting. And certainly worth keeping in mind is that even if the acute episode is identified and contained, there still is that chance that in the time that this disorder was having its way, that there are issues that can persist beyond resolution of the acute phase. And so that's important, and even more emphasis on why it's important for quick identification and treatment. What are some nursing considerations you would suggest for patients with ITTP or a history of ITTP, or who may be at risk of developing it?
In patients who have TTP, a lot of their care is managed in the ICU just because of the plasma exchanges that need to happen. And then again, the thrombocytopenia, the hemolysis, all of those require the expertise of ICU nursing physicians. But those patients, they survive, they go into remission, and they become outpatient in establishing a relationship with these patients once they've kind of come out the other side. It's understanding how to triage their disease. If the patient calls you with concerns, how would you address those concerns? How would you find out if there's something going on or not? A lot of times, just given how acute the onset is, and a lot of these patients have some PTSD. And so there's a lot of worried well conversations. And then in the outpatient, you still need to figure out how to coordinate future care given their history of TTP, because even if they're in remission, like we had mentioned, some folks go into, they relapse, and it's not particularly understood what one thing will cause a relapse in one person or the other, but they happen in people who've gotten sick or major surgeries, just major hits to the immune system. So even in cases where patients need to get vaccines, we have to make sure that the patient is safe and knows the symptoms to look for.
I think you've really highlighted the importance of, like you mentioned, the coordination of care across those transitions. And so if it's from a unit to an ICU level, if it's post-discharge in the outpatient world, in an infusion center, in an ambulatory setting, I mean, all of those areas have different roles and responsibilities, but they all need that same understanding and awareness, not only of the patient's history and their own individual risk factors, but just of this disorder in general, and how important it is to have that information so that we are keyed into the right factors when we're assessing that patient. So you've done a great job of really highlighting that, and how we all have a role to play, even if we don't feel like this is something we're going to see very often. It's still a possibility.
Yes, ICU nurses can definitely see these cases in the outpatient setting. They're patients that we see for years and years and years, just monitoring them and surveilling them and helping them make appropriate healthcare decisions and get on with their lives.
Absolutely. It definitely, again, highlights just the importance of when you are transitioning, whether you're a nurse actually giving a report to a different unit in that sort of formal handoff, or if you're in that ambulatory setting where the patient's coming back to the clinic for the first time post-discharge, just again, reviewing, understanding kind of what that patient's last episode of care was, so that you always have that current information to work with. So that's really important in this situation, it sounds like. You already mentioned it, but what are some of the ways that nurses can support patients with cancer who have TTP, whether that's during kind of active treatment for TTP, or if it's after their acute condition has resolved and they are in that sort of long-term surveillance?
I think it's important to be mindful of, specifically in cancer, like I had mentioned earlier, that it's either a symptom of disease or caused by the treatment. So you could potentially just have a new cancer patient, and along with this major acute crises that they've had, so dealing with a cancer diagnosis and having had TTP, or trying to figure out if it was medication, how do we resolve that? Are we able to find a different drug and switch to a different regimen, or do we continue to give it because it's the only therapy, and do we have to continue to be on the lookout for relapse? And I think those would be the major concerns with a cancer patient.
Absolutely. And as you mentioned before, the emotional support piece of that, of those patients who are maybe back in our outpatient world and doing okay, but just concerned about it. And that just emphasizes, again, the importance of doing that distress screening on a regular basis, talking to our patients, asking how they're feeling. And sometimes it's just reassurance that we can provide them, that we're watching, whether it's their lab results or we're doing these assessments. And so we're with them and we're doing our best to watch for any concerning symptoms and just provide them with that reassurance that we're partnering with them in their care. Well, we've tackled a lot in this short episode today. I've learned a lot. I mean, again, it's one of those things that I think as nurses, we have a very distant awareness of, and it sounds familiar when we hear it, but sometimes it's hard to really verbalize what it is or what it means. So you have really been helpful in breaking that down into a simple way for us to understand. So as we conclude our episode today, we just like to always ask a few little quick fire questions to summarize what we've talked about. So to start, what are some common misconceptions about TTP?
I'm not sure that there are a whole lot of misconceptions in and of the issue being that people aren't terribly aware of it. I guess I would backtrack and make sure to highlight that TTP looks very similar to a whole bunch of other diseases, but it can be sorted out And it's important to have the knowledge that this disease exists and that you may see it in your career sometime.
What is something about TTP that's not often discussed and you wish people knew more about?
I kind of would pull back a little bit and say the thing I wish specifically more oncology nurses knew about is that there's a whole slew of non-malignant hematologic diseases that kind of get lumped in the oncology world. And a lot of people aren't aware of these diseases and get very flustered when they encounter patients with these diseases. And I have people coming into non-malignant hematology. I try to remind them that we have the same concerns as patients with hematologic malignancies. It's just, it has a different name.
That's a great comment. And it is a little scary.
Yeah. It's a very wide world. And I feel like some of these non-malignant patients often are kind of forgotten in lieu of taking care of oncology patients. It's important to remember that these zebras are hanging out there.
Sure. And it's complex, but it's also not something beyond the realm that nurses can learn and understand. And I think you've done a great job of introducing us to that today. So similar to what you've just mentioned, what are some additional training, education opportunities or resources that nurses should look to if they want to learn more, whether it's about general non-malignant hematology or if it's about TTP specifically?
I think just kind of going back to the basics is important, like learning how to read and understand the labs that we are frequently drawing on these patients. Just what is truly a platelet count, or what do schistocytes mean on a smear, and understanding those to help put the puzzle pieces together. And then also understanding how to triage based on the patient's history or their concerns, just how to talk to someone and really suss out the symptoms they're having, if it's likely related to their disease or if it's something else, as triage is kind of a hard skill to master, and specifically in hematology.
I think those are both great recommendations. As you had mentioned, we have to challenge ourselves as nurses to go beyond just reading the normal range that our lab printout gives us and really ask ourselves, well, do I know what that means? Do I understand the significance behind these values? And as you mentioned, even more so important than being able to apply that critical thinking to then advise our patients accurately based on the findings that we're looking at. That's especially important when we're dealing with hematology that is so based in those labs that we're getting. So I think those are great recommendations of really just getting back to basics and asking, do I really know what this means? Do I understand the implications of what these values mean to my patient? So great, wonderful recommendations. And Amanda, thank you so much for joining us today and sharing your knowledge about this complex and unique condition. Do you have any final comments to share with our listeners?
If you're interested in learning more specifically about this disease or even other non-malignant hematologic diseases, the American Society of Hematology has a lot of resources that are easily accessed by everyone. And then the Organization for Rare Diseases is also a good place to stop by and learn more about the diseases, and then also the resources available to help the patients who are living with them.
Wonderful. Well, we'll be sure to include those links in our episode notes for our listeners to access as well. Thank you again. Thank you so much for sharing your time today.
Thank you very much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.